All right, good morning, everyone. Thank you for joining us today. I am here with Lori Gephardt and Sabah Basanthi, and they are excited to hold this training for you all. And I think it'll be a really good one. Before we get into the content, I did just want to remind everyone that you are in listen-only mode. So if you have comments or questions, go ahead and type them into the chat box or the question box. That will send to me, and if we have time at the end, we will try to go through them. As always, if we can't go through them, I will compile the questions and we will start to create a handout with answers. At the end of the training, we are going to do the assessment a little bit differently now that we're using this new platform. The assessment will come as a link I will provide in the training, and it will also be emailed to you about an hour after the training closes. So be on the lookout for that, but I will also remind you all at the end as well. So without further ado, I'm going to pass this over to Sabah and they will take it away.
All right, good morning, everyone. My name is Sabah Basanthi. I'm one of the nurses here in state office. Last year, I had the privilege of being a stand reviewer, and now that I'm back to my original duty, I am still assisting with stand reviews. So some of the discussion today will be based from documentation in the handbook and experience as a stand reviewer and also a medical case manager in the field. Today's discussion we will review the iBudget handbook requirements for private duty nursing, residential nursing and skilled nursing services, state plan Medicaid nursing services, Medicare nursing services, some durable medical equipment and consumable medical supplies, and the process for transitioning from nursing services from Medicaid state plan to the waiver. And hopefully after today's presentation, you will walk away with a clearer understanding of private duty nursing, residential nursing, and skilled nursing services and the differences in those services. You will walk away with some understanding of durable medical equipment and what we pay for versus what Medicaid pays for, and some understanding of provisions of nursing services under Medicaid state plan. Okay, nursing services. Waiver under certain circumstances will fund skilled nursing, private duty nursing, and residential nursing services. However, we are typically the payer of last resort for the services. You have to do some little research on your own by tapping into natural resources. Now, if natural resources are not available, or if they are available but can't do all of the services all of the time, then you look at other funding sources like private insurance, Medicaid, Medicare, and then waiver. However, under waiver, medical necessity for the service has to be determined for waiver to fund the service. Each time a service is renewed, or if it's a brand new service, we have to determine medical necessity for that service. And we'll get into transitioning from state plan, but just keep in mind that just because someone has been receiving nursing services or has been getting 24 hours of nursing services from state plan doesn't always mean that it's going to carry over under waiver. We do medical necessity services for every service and supply to determine if the service is still necessary that the client still meets criteria for the service, and that the service is in line with the definition of said service in the handbook. And one other thing, I've heard statements like, well, the doctor prescribed it. Well, we still have to determine medical necessity. And we're not saying the doctor is wrong. Sometimes they don't know everything that's going on with the client, so they may prescribe 24-hour nursing service. We still need to look at the service to determine if 24 hours is really necessary for this client. Private duty nursing services are provided in the recipient's home or family home, or when a recipient who lives in those settings is engaged in a community activity. It is prescribed by a physician or nurse practitioner or physician assistant, and it's for waiver to fund it. It's for recipients 21 years and older who are eligible for active nursing intervention for 2 or more hours in a day. Private duty nursing services cannot and should not be used for oversight of direct care staff in the client's home or monitoring of caregivers in the home. The client must be receiving active nursing intervention, meaning tasks and duties that cannot be delegated to a direct care staff provider. Now, in a family setting, you can train the family, the parents or grandparents or whoever is in the home with the client to provide those services. So in some situations, you'll have nursing in the home for maybe 16 to 18 hours a day, and then the rest of the time, the family will provide the service because they've been trained by the nurses to do those services at home. Again, medical necessity for this service still has to be established. And the medical necessity, some of you may be familiar with it already, but it's in the handbook. I should know the page, but just search for medical necessity and familiarize yourself with all the steps regarding medical necessity, because that's what we look at when we review services here.
1-7.
Page 1-7 is the medical necessity criteria in the handbook. Residential nursing. I've seen where private duty nursing, residential nursing, and skilled nursing services are used sometimes inaccurately. Residential nursing is provided to a recipient 21 years and over who resides in a licensed residential facility, like our group homes, or for that client residing in that facility who's engaged in activities in the community. Again, like private duty nursing, residential nursing is prescribed by the physician, the client's healthcare provider. It could be the doctor, the PA, or the nurse practitioner. And just like private duty nursing, it cannot be used for ongoing medical oversight or monitoring of staff in a group home or foster home or wherever the client is in that licensed facility. And it's limited to clients 21 years and over who require active nursing intervention for 2 or more consecutive hours. Okay, now for the fun stuff. Documentation requirements. Some of the documentation listed on here are for billing purposes. The nursing care plan, progress notes, monthly summaries, but as far as reviewing services and determining medical necessity here for these services, we look at the nursing assessment, a current nursing assessment. We look at the plan of care. We also rely on the nurse's notes. We typically ask for anywhere from 3 to 6 months of nurse's notes because the nurse's notes help in some situation paint a picture of what's going on with that client on any given day. Because sometimes the nursing care plan is just a synopsis, and sometimes they're helpful, sometimes, I'm being honest, they're not. So we look at the nurse's notes. We look to see what is it that the nurse is doing when they check into their client's home or the setting where the client is, where the service is going to be provided, what they are doing for that client from the start of their shift until they turn it over to the next person. We look at the nurse's notes to help us determine if the service is medically necessary. We look at the duties, and sometimes the nurse's notes will help us figure out the duties, but sometimes we still have to reach out to you, the waiver support coordinator, to get the list of duties that the nurse is providing. We also look at the QSI. We rely on the support plan, and also, please take a moment if you have your packet in front of you to add medical case manager report. That's the report that's done by the nurse in your respective region. We forgot to include it on here, so if you have your packet, just pencil it in, the NCM report. And one other thing we also would look at is the EQ letter authorization that comes from EQ. So just pencil that in as well. As far as these documents, when you submit your documents like the QSI and your support plan, you want to take a look at the QSI and look at your support plan. Those two documents need to speak the same language. We've seen situations where the QSI says one thing, the support plan says one thing, the nursing assessment says one thing, and we're sitting wondering, okay, so what is really going on with this client? So we look at these documents. We don't just ask for them just to be asking, but we look at them in detail to help determine the best plan for this client so the client will have the best outcome from their services. So take a look at your support plan and your QSI and make sure that the information is accurate. If it needs to be corrected, by all means, do not hesitate to correct the information, but we've seen a lot of discrepancies with these documents. Now, okay. We decided to just include some examples here for you. The difference between private duty nursing and residential nursing. Again, residential nursing is in a group home or licensed facility. Private duty nursing is in a client's home, could be their own home or family home. Private duty nursing, an example here is an individual 32 years old who lives at home with elderly parents, has a G-tube, and is fed via a pump 24 hours a day. Sometimes the pump can be at a different rate from 7 a.m. to 7 p.m. and then 7 p.m. to 7 a.m. it's at a different rate. Residential nursing, again, in a group home, client has a tracheostomy and a G-tube. The individual with the G-tube also has feedings from 7 a.m. to 7 p.m. Now, speaking of G-tube, just because someone has a G-tube doesn't always mean they need private duty nursing. That's why it's important when you present your documentation, you let us know. Well, not necessarily you, but if the documentation you're requesting from the nursing agency providing the service, it's not just enough to say, oh, the client has a G-tube and it's fed through the G-tube. That doesn't help me or any of the reviewers in any way determine the level of service, nursing service this client needs. I've seen statements like it's fed 4 times a day. We need to know what's going on at each feeding. A suggestion when you're visiting your clients, pick a feeding time so that you can observe the nurse doing the feeding so that what's written on paper will make sense to you when you see it in motion. I'm a visual learner. When you see it and you read it, Most of the time, it will make sense to you. But we look at what's going on at each feeding setting. Is it through a pump? Are they taking out the plunger from the syringe and pouring the formula inside the syringe? We need to know more than just G-tube fed in your documentation to determine medical necessity for this service. How long does it take to feed this client who's fed 4 times a day? Now, if you're on a pump, you can kind of figure out what's going on, but some pumps go on at 7 p.m. and stop at 7 a.m. And then during the day, they may get 1 or 2 feedings via gravity or through a syringe. So we need the whole picture and not just G-tube fed 4 times a day or 3 times a day or every 6 hours. And when you gather your documentation from the sources, please ensure that you're able to read them. We're not asking you to interpret what's written on there, but there have been times when we have to enlarge the screen to 150% to see what's written, and even then it's very difficult to make out. So when you're sending stuff through, I know when you get it through faxes, it tends to just get blurry after a while. So you want to ensure that the documentation that you're sending is legible. Anything else, Laura, you can think of?
I think that's for that.
Okay.
All right. My name is Lori Gebhardt. I'm the program administrator here for APD for Clinical Services. And I, like Sabah, but probably not as much as Sabah, review some of the cases that come through here. So Sabah's talked about residential nursing and she's talked about private duty nursing. And those are the types of nursing where it is continuous. The waiver also pays for another type of nursing, which is what we consider to be skilled nursing, or as Medicare and Medicaid call it, a home health visit. So for the most part, a skilled nursing visit is a part-time or intermittent, you'll hear the word intermittent used, nursing visit that's provided either daily or weekly or monthly, and it's provided by either a registered nurse or a licensed practical nurse. Skilled nursing can be provided in the client's own home or other waiver sites, such as an ADT program. It can be provided in a family home, a group home, supported living. So again, and Sabah has reviewed some of this with you, but some of the documentation requirements are for billing, and some of the documentation requirements are what we look at to review for medical necessity. So with regard to skilled nursing, much of what's here is the same as you would review for the other nursing services. So we need a care plan and we need for them to be annually updated. We need daily progress notes, and for the nurses, it's generally the nurses' notes. And as Sabah also told you, we sometimes request generally 3 months, but sometimes all the way up to about 6 months of nurses' notes, and we read them. What we are trying, or what we are looking for, is what the nurse is doing. We look at what the original prescription says. Sometimes we look at the monthly summaries, which also include information like, medications, treatments, medical appointments, how the individual is actually doing. We look for, and this is supposed to come from the physician, a list of duties to perform by the nurse. What we sometimes see is that the physician says that the individual needs nursing, and then he says to bathe, to feed, and to help ambulate. Well, those aren't specific skills that you need a nurse for. And that's why, when Sabah explained, when we look at medical necessity, we look at those things. We look at the support plan. Missing from here also, so if you want to take out your pencils and just kind of fill in, we look at the QSI, and we also look at the regional MCM report. And also, if they've been getting nursing prior to through either the plans or EQ, we look at what they've approved. Now, skilled nursing is a little bit different because we're talking about a visit. So the nurse goes in and does what needs to be done, and then they leave. So a good example of that is insulin. One of the additional, can we go back to the previous? One of the additional documentation requirements that we need specific to skilled nursing is an exception letter from ACA for the skilled nursing services. And the reason for that is because Medicaid state plan pays for home health visits for both children and adults. So in order for the waiver to pay for a skilled nursing visit that Medicaid should be paying for, we have to go through the ACA exception process, and they generate a letter for us, and that's done on an annual basis. The ACA exception process with regard to skilled nursing is not new. There has been a process in place since 2012. At this time, we probably have about 30 to 35 letters of exception. So some of you may be familiar with the process, some of you may not, especially if it's not something that any of the individuals that you are providing services for require. So basically what it entails is we require a physician visit documentation form and the physician's written prescription, and those are, ACA has a form for that. The medical case managers in the regions work with you with regard to this process. They should all be very familiar with. We also require an MCM report. Part of what you all have to do is you have to contact the Medicaid office. There's one central, it's located in Jacksonville. That individual has to be contacted, and they will give you a list for home health agencies in your region that you have to contact, and you have to document on paper for us as to what their response is as to whether or not they could provide the service. And then we also require a copy of the support plan, where again, there's documentation there that the individual requires skilled nursing. Presently, we're looking at, I've asked ACA to take a look and see if we can update the process. And depending on what happens with that, we'll let everybody know. So let's look at a couple of examples with regard to skilled nursing. So again, one of the classic ones is that we have individuals that are either in their own homes, they're in group homes, they're in supported living environments that require insulin. So in this case, this individual requires insulin QID, which is 4 times a day at the group home. So the waiver support coordinator and the nurse have gone through the process. They've checked with ACA, they've gotten the list, and there are no Medicaid providers who will staff this for whatever the reason is. So for this one, we would have to follow the exception process, and generally ACA will give us approval. They'll provide the letter to which we will provide for you, and then the service can be provided. So here's one where we have an individual who requires wound care daily in their own home. Again, there are no Medicaid state providers that could be found after going through the process. We would follow the exception process, and ACA would issue us a letter. Another scenario could be that the individual requires 4 intermittent nursing visits every day for urinary catheterizations. So what was found was the Medicaid state provider, there was one, but they could only provide staff for one visit a day. Medicaid state plan will pay for up to 3 visits for somebody who is over 21 years old. They will provide up to 4 visits for somebody who is under 21. So in this case, if we have a Medicaid state provider who will provide 1, we would go through the exception process so that the waiver could cover the other 3. In another example, we had an individual who required insulin injections 4 times a day. A Medicaid state plan provider was found and they were able to do the 3 visits, but this individual required 4. So the waiver will cover or can cover that 4th visit. And because Medicaid only pays up to 3 visits for an adult, we wouldn't need to go through the exception process. We would be able to just approve that.
That's me. Okay. Again, if you have your pencil or pen, add on this page, children only. So under 21 years old for Medicaid state plan private duty nursing. And this information is found in the Medicaid state plan coverage and limitations handbook.
They've changed it. It's the PDN service coverage policy.
Okay, we have the expert here. PDN services coverage policy. It's right there on the top, page 3, section 4.2. So I'm not going to go through all of it for you, but just we forgot to include that this private duty nursing under state plan is for children. Medicaid state plan will cover private duty nursing, will reimburse services for up to 24 hours of private duty nursing per recipient, but they have to meet the criteria listed on here. They have to be under the care of a physician and has an order from the doctor for the services, requires more extensive and continual care that can be provided through a home health once in a while intermittent type visit. And requires services that can be safely provided in their home or community. But for those who need less than 2 hours of private duty nursing, we would have to refer to the Medicaid home health visit services that Lori just covered for you for intermittent services. Okay, pencil or pen again. This is for children and adults. Medicaid state plan will reimburse for home health visits up to 4 intermittent home health visits per day for clients under the age of 21 and pregnant recipients 21 years and older. So if you're pregnant and 21 and older, you can get up to 4 intermittent home health visits per day. Now, if you're 21 and older and you are not pregnant, Medicaid, like Lori said earlier, will reimburse for up to 3 intermittent home health visits. This is where the nurse comes in, does what he or she has to do, and leaves, and then come back when the service is due again. That's the definition of skilled nursing visit. Intermittent visits.
Before we go to Medicare, let me just mention that for a very long time, services under Medicaid were only under fee-for-service. But these days, nursing services can also be provided under managed care plans. So unfortunately, when we talk about Medicaid services, you all need to be aware that while our individuals aren't mandated into managed care plans, many of our individuals actually do get services through managed care plans because some of them pay for additional services. The significance of that is that if the individual has fee-for-service Medicaid, then the nursing services and I believe equipment is it goes through prior service authorization with EQ Healthcare Solutions. If they are under a plan like Sunshine, they have their own care coordinators who do that prior service authorization. So for us, it's a little bit more work with regard to trying to figure out, first we have to figure out what kind of Medicaid they have, and then if it's fee for service, sometimes we have to go to EQ for some assistance, and if it's a plan, it's a little bit more difficult because we know a lot of the care coordinators through EQ, whereas each plan has their own. But that's something that actually you need to be aware of. The other thing is that fee for service, as with waiver fees, are fixed. We have no ability to change them, whereas the plans, they all have some leeway with regard to what their actual fees are. So sometimes for the plans, it's easier for them to provide a nurse, whereas under fee for service, we can't find. Okay, so let's go to Medicare, and I've given you a lot of information. I'm not necessarily going to spend a lot of time with regard to. For any of you who have tried to navigate through the Medicare system, it's very difficult. And it's not easy, and they don't necessarily always want to talk to you. But unfortunately, when we look at the hierarchy of payer services or services that are then funded, if somebody has Medicare, we have to look at it. So as I said, I've given you a whole bunch of information here. I'm gonna sort of go through and highlight some of the Medicare pieces. But you really have to have their manual in front of you, and even when you have the manual in front of you, you still need some help. The Medicare Home Health Manual, it's the Medicare Benefit Policy Manual, is Chapter 7, and I don't know that we've given you some sites at the end. I don't know that we necessarily gave you that, but we can certainly send that out to you in case any of you are interested. It's also very easy to Google on the internet. But anyway, it's Chapter 7, Home Health Services. So unfortunately for you, Medicare does pay for some nursing services, and their nursing services are considered to be a home health visit. So if you have somebody who has Medicare, but they need 24 hours of nursing, then Medicare isn't going to pay for that. We know that. If you're looking for a home health visit and your individual has Medicare, then we have to do our due diligence with regard to figuring out and finding out whether Medicare in this situation will pay for or fund. So for the most part, a home health visit under Medicare isn't that much different than under Medicaid or the waiver. So for the most part, home health care includes a wide range of health services that are delivered in the home to treat the illness or the injury. The service covered under Medicare includes intermittent, there's that word again, it's intermittent, it's in and out nursing care. It also includes therapies. It also can include services provided by a home health aide. So depending on the circumstances, home health under Medicare could be covered under Part A, and it could be covered under Part B, or it could be covered under Part C. The other piece that you need to keep in mind is that Medicare has a very specific definition for homebound. And they stick to it for the most part. So Medicare has this homebound requirement, and they consider you to be homebound if you need the assistance of another person or some type of medical equipment in order to leave your home. And your doctor believes that your health or illness would get worse, or it would impact your health if you had to leave your home. And it has to be very, I should put a very difficult for you to leave your home. And typically, you don't leave your home. So for the most part, if you have somebody who is really ambulatory and out all the time and they have Medicare, Medicare most likely will not cover. If you have an individual that is home, that is bedbound, Medicare could cover. So as I said before, you can receive home health care coverage either under Part A or Part B or Part C. I'm going to just very quickly tell you what the differences are, but I'm not going to spend a whole lot of time under this. The other thing that you need to remember is Medicare has a copay. Generally, it's 20%. So under Part A, that's the piece that covers hospital stays, a stay in a skilled nursing facility, or some home health or hospice. Part B is the piece that covers your physician visits, your outpatient visits, your preventative services, some home health, and your labs. Part C is what is referred to as your Medicaid, Medicare Advantage plans. And those are generally an alternative to traditional Medicare. And instead of having Medicare benefits through the government-run programs, you're getting private insurance companies that contract with Medicare. And the Medicare Advantage plans generally include prescription drugs. They may include vision. They may include dental. But Medicare Advantage plans may have different rules. They may have some different restrictions, and they definitely have different costs.
Oh my, oh me. Ah. Durable medical equipment. Who pays for tubes, gauze, tape, suction, vents, tracer? Oh my goodness, who pays for what? Listen, we need a whole session on DMEs and CMS. But we'll talk a little bit about some of the stuff here. Many DMEs, durable medical equipment, are limited to recipients under 21 years of age. And to determine whether a service is available to all recipients or limited to just those under 21, you have to refer to the good old fee schedule. So if you don't have it, I suggest you ask for it, or it's on the AHCA website.
And we gave them that site at the end.
Yes, and you have the link to those sites, I think, on the last couple of pages here. So I just take some time, go through the table, go through the spreadsheet. If you have questions, email us, call us, and let's talk about it. But like I said, we need a whole session on DMEs and CMS. So we'll just do a little bit about some DMEs and some CMS and who pays for what and who's on third base. Okay. Respiratory supplies. If you have a client who has a tracheostomy and is on a ventilator or not on a ventilator, but has a tracheostomy, majority, I want to say 99.99%, if not all of their respiratory and ventilator supplies and tracheostomy supplies come from Medicaid. I've heard DME suppliers tell the waiver support coordinators that, and it's in writing, they've emailed the WSC to say they don't like the reimbursement rate. So therefore, they want waiver to pay for it. Nah. We're not going to pay for it just because they don't like the rate. They need to take it up with Medicaid if they don't like the rate, but if it's an equipment that Medicaid will pay for, then Medicaid should pay for it. Waiver will not pick up that cost just because they don't like the money they're getting for it. G-tubes. For majority of the G-tube supplies, your G-tube extensions, Medicaid pays for it. And if Medicaid pays for G-tube extensions, I don't see why they can't pay for the pumps and the bags. But waiver will pay for the bags up to 30, or I believe it's 31 bags a month. And we will help with the rental of the pump. For adults, remember, we're talking about adults here. Yes, Lori G just reminded me, I'm getting a little carried away, but we're talking about adults for waiver, reimbursement. So just keep that in mind. What else is on here? Medications, I've seen requests for medications through waiver. We don't pay for medications except for, and I meant to get that information from the handbook, bowel medications to help the client's bowel movements. We pay for some, not all of it, but nebulizers and inhalers and medications that you would typically get from your pharmacy goes through Medicaid for everyone. Ostomy supplies are reimbursed under Medicaid state plan. Things like Q-tips and zinc oxide and ointments for your bottom, things that we would term general utility stuff that you can go to CVS or Walgreens and get, waiver is not going to pay for it. Urinary catheter supplies, funded again through Medicaid state plan. Formulas for G-tubes. Medicaid should pay for all formulas for G-tubes, but we're having some issues with some formulas, especially the complete formula. It's like once you age out and you turn 21, you are pretty much on your own. However, ACA is developing an exception process for certain formulas that the family caregivers will have to go through if the handbook as it is now, the Medicaid handbook wouldn't allow for certain types of formulas to be funded through Medicaid. They are developing an exception process for the families to go through with your assistance, of course, for your adult clients, for the formulas to be funded through Medicaid state plan. What helps us here with supplies and equipment? We look at not just prescriptions, because some of the prescriptions aren't really helpful, but we need prescriptions for these items. But we rely highly on quotes from your suppliers, and I mean itemized quotes from your suppliers. So if you can, make sure you're requesting for quotes from your suppliers. And one thing I would like to suggest when creating sand screens for these supplies, try not to group things together. Diapers, wipes, and pads pretty much have their own code. You can have separate screens for those, but I've seen cases where everything is just lumped together and it takes a while for the reviewer to go through each item. It delays the process, and then you're getting anxious because your client is about to run out of money. You need the services approved. So help us help you by getting us the documents that we need to review these the services and supplies. And like with private duty nursing, residential nursing, and skilled nursing, we still have to determine medical necessity for these items. An example we had a couple of days ago is a request for surgical mask. Even though the handbook allows surgical mask for your adult clients, the criteria in the handbook, page 2-26, still needs to be met for waiver to pay for surgical masks for your clients. So we still have to determine medical necessity.
No, they just need to remember that for the most part, Medicaid pays for most services with regard to DME and consumables for children. Once they turn 21, some of the DME and consumables go away. And that's why you need to be able to refer to the fee schedule. Unfortunately, I'll give you a little bit of a hint. The new fee schedules, unfortunately, don't have any descriptors. So they're not necessarily, it's not necessarily the most helpful. Some of us have kept our old fee schedule so we know what each of the codes mean. And then there is a general code. I believe it's national codes that we sometimes also go to. HCPC codes. All right, I've been reminded that we only have about 10 minutes. And certainly, if you have questions with regard to the DME, you have resources. We'd rather hear from you and have you ask than for us to have to backtrack. It's so much easier for us to do it once as opposed to, going back and forth. So certainly, the MCNs in the regions, and we're up here also. So if you have questions, please ask. The one thing that we don't want to see is that we get a list of DME and supplies all on one page, and it's asking for the waiver to fund. Y'all have to do your due diligence with regard to what Medicaid funds and then what we fund. Okay, one of the last things that we wanted to talk to you about and just sort of go through is the transitioning from Medicaid state plan nursing services to waiver. And this is, for the most part, for the individuals that are turning 21 years old who have had services under state plan. So this is for your individuals that have 24 hours of nursing, or they've got personal supports. They may have therapies, meaning OT, PT, speech, respiratory, and they have a laundry list of DME and CMS. What we want you to know and what we want you to take away from this piece is that y'all need to be doing transition planning about 6 months ahead of time, because that's about how long it takes to get all of this together. You do no one any good when we get contacted on Friday afternoon that the individual is transitioning on Sunday. And the reason I'm saying this is because if an individual is receiving 24 hours of nursing through state plan, the managed care plans and EQ are preparing for transition. They start 6 months ahead. If an individual is in a nursing facility, they do transition planning every 3 months. All care coordinators through Medicaid, whether they are a plan or EQ, they provide choice counseling, which provides all options for services to the individuals and or families or legal representatives. And what that means is they review with those families ACA's long-term health care plan choices and APD's waiver services. And I will tell you that up until not a long time ago, ACA's long-term care plan choices were very, very limited and nobody chose them. But what we have been seeing is if an individual chooses to remain in their home and they have been served by a plan, we have been seeing them opt out of waiver services and continue with the plan because the plan has been able to better meet their needs for the nursing services. If an individual chooses to receive APD waiver services, then APD should be included in these transition meetings. So this is just what we would consider to be best practice in terms of planning for transition. So 6 months prior to an individual that you all have that is going to turn 21, who has those types of high-level skilled needs, the needs need to be identified about 6 months prior. You need to gather all the documents that we're going to require to look at, and that may also include contacting the providers. You need to be part of those transition meetings. So again, if you have an individual that you are either working with or have inherited, you need to ask whether or not these transition meetings are taking place, and you need to be asked to join. You also would probably need to update the support plan so that the support plan will show us an updated or what the individual's updated needs are. About 3 months prior to them turning 21, you really should submit the SAM so that when they actually turn 21, it's a smooth transition. And again, the nurses in the MCMs, the medical case managers, can work with you on this. Any questions, you do have resources. So what we've provided for you here is a couple of the ACA coverage policy handbooks. So one of them is ours, the iBudget waiver services, and you should all be familiar with that. That should really be, you know, your guide. We provided you with the ACA DME policy coverage. We've provided you with the ACA home health visit services coverage policy. And we've also provided you where the private duty nursing services is. The one thing that we didn't provide you with was the Medicare, and we can certainly, Elizabeth can get that out to y'all. So if you still need help, your local staff, your local APD staff can be found on our website. It lists the regional staff, and basically you've got your medical case managers, you have clinical workstream leads, you have waiver workstream leads, and I guess I could also have put down there you've got waiting list workstream leads. There's a lot of support, or there should be a lot of support in the regions. If you have further questions that you can't get answered, or you need more information, both Sabah and myself are available, and we're more than willing to answer questions. You can go through Elizabeth and she will let us know. We'd like to thank you.
Yes, thank you.
Okay, so we are at the end of our time. I think we maybe have like 2 or 3 minutes.
Sorry.
So I am going to suggest that I'll just compile all the questions that came through, and we will go through, work out those answers. And of course, they get posted up on the website, and all of our support coordinators can reference that whenever they need it. To get everyone ready for their assessments, I have a few announcements. The first one, like I said at the beginning of the call, we are going to do our assessment through a different service. So in the past couple months, you guys have been taking your test on WebEx. Obviously, since we are not using WebEx, I had to find an alternative. So the alternative is an online software program called ClassMarker. And we are going to go back to, if you were doing these calls almost a year and a half, 2 years ago, there was a link. And so we are going to have to go back to that link option. But what I've been able to do is provide it to you here. So if you want to take a moment and just write this down, you are welcome to do that. I will also put it in the chat box so you guys can copy and paste it if you would like. And then the third option is to actually wait about an hour and you will receive an email from GoToWebinar thanking you for joining our call. And within that email body, there will be the link to the test. So again, it's only open for today. I believe, yes, the test will close at 5 p.m. today. So throughout the day today, during normal business hours, I will be diligent to answer my emails. I know that there are always questions about the test, and specifically since today we're doing a different process, I will make sure that I get to every single email that comes in before I leave at 5 o'clock to make sure that everyone has the opportunity to take this test. But once you take the test, it will generate a certificate, and on that certificate, it will tell you your passing score. If you get a 75% or higher on this test, you will receive 1.5 in-service credits. If you get 74% or lower, you will not receive your in-service credit for this training. That doesn't mean you didn't have valuable information or have a great time today. It just means that next time you may want to read through those questions a little bit more closely. So I will leave this up for a couple more minutes, let everyone get a chance to write it down. If in about an hour or so you still do not have a link, just reach out to me and I'll be happy to share that with you. So I will say thank you for joining us, and I hope you all have a wonderful Friday and a wonderful weekend. Have a great day.